For our next section, we're going to talk about the parathyroid glands, and especially in that context with the parathyroid glands, we're going to talk about calcium metabolism, especially hypercalcemia and hypocalcemia. Let's talk about some general issues based on this figure about calcium metabolism, and we're going to talk about the key players that are involved in calcium metabolism and the key players that sustain a normal calcium level in our serum. So the most important hormone, of course, is parathyroid hormone, this right here. This is secreted by the parathyroid glands, PTH, and it stimulates the osteoclast in the bone, basically to break down bone and release calcium into the serum, because remember, parathyroid hormone's main process is to keep the calcium in the serum stable. Otherwise, if the calcium drops, you would go into tetany and develop tetany and so forth. But so parathyroid hormone stimulates the osteoclast, and you break down bone and release calcium into the serum, and then it does a couple of other things. It increases distal tubular reabsorption of calcium from the kidney. And then another very important thing that it does, this one we have to know about right here, the effect on phosphate. Now, even though it reabsorbs calcium, what it does in the kidney is it increases the secretion of phosphate because it blocks the reabsorption of phosphate. So really, parathyroid hormone increases calcium in the serum many ways, either by activation of osteoclasts or by affecting the kidney. And what it does to the phosphate is it decreases phosphate in the serum, basically by blocking reabsorption of phosphate through the kidney. So the second player that's very important in calcium metabolism is vitamin D. And vitamin D plays a big role in calcium metabolism because it increases calcium absorption from the GI tract, and we're going to talk about that. But first, let's talk a little bit about how vitamin D gets absorbed. And there's two processes. One process is through the skin. So you absorb vitamin D through the skin, through the sunlight. So people that don't have access to sunlight, they're living in long-term facilities that are bedridden for a long time and don't go out into the sunlight, you decrease the amount of vitamin D that you absorb from the skin. And this has been the focus of some studies in the last 4 or 5 years that have shown that people living in older patients, living in long-term facilities, living in basically that are bedbound, they don't have access to sunlight, get a relative vitamin D deficiency. So think about that. And then the second way that we absorb vitamin D is through the gut, through our GI tract, through food, along with the other lipid-soluble vitamins, right? Vitamin A, vitamin E, vitamin K. And what you need is pancreatic enzymes for that. You need vitamin D in the food. Then you need pancreatic enzymes. So people with chronic pancreatitis, for example, can't absorb vitamin D, and they get a vitamin D deficiency because you need the pancreatic enzymes to basically absorb it in the small bowel. And then the third thing that you need is, after you have enough of vitamin D in the food, after you have pancreatic enzymes, you need an intact small bowel surface to be able to absorb vitamin D. So patients, for example, that have celiac sprue, tropical sprue, Whipple's disease, proximal Crohn's disease, they have malabsorption syndromes that affect vitamin D, and these patients develop vitamin D deficiency. So what do we need to absorb vitamin D? We need sunlight to be able to get it from the skin. We need it from our food. You need vitamin D from your food and your milk products and so forth. We need pancreatic enzymes to be able to absorb it, and then we need an intact small bowel surface to be able to absorb it. So think right there, you have about 3-4 etiologies that could cause vitamin D deficiency, right? No access to sunlight, right? Pancreatic insufficiency, food, if people are not eating the right food, and then number 4, small bowel disease like celiac sprue. Think about that, because that would be your differential diagnosis of vitamin D deficiency. After we absorb enough vitamin D, we still got a little bit way to go. We need to hydroxylate it at 2 different sites in order to be able to have the active type of vitamin D. So the first site is right here in the liver, the 25th site. You activate it through the liver, and now it's called 25-hydroxy vitamin D. And then the clinically most important site is the first site right here. So after you hydroxylate it in the liver, it goes to the kidney right here, and you hydroxylate it at the one site. So now it's called 125 vitamin D, hydroxy vitamin D, and now it's activated and now it works, and it's supposed to do what it's supposed to do with calcium metabolism. So basically, beyond all the stuff we talked about the skin, about the GI tract, you need an intact liver to hydroxylate your vitamin D and an intact kidney to be able to hydroxylate it and activate it. So right now you should know a good differential diagnosis about possible vitamin D deficiency. You think about skin disorder, people that don't have access to sunlight and they don't absorb it from the skin. Think about GI malabsorption. Think about cirrhosis. Think about kidney dysfunction. Out of these two, liver disease and kidney disease, the one that's most clinically important is the renal causes. The reason is because even with mild and moderate renal disease, you could have malabsorption, or I shouldn't say malabsorption, non-hydroxylation of vitamin D, so you don't have active vitamin D, even with moderate disease. So in people with glomerulonephritis, for example, or any other type of form of chronic kidney disease, even before their creatinine starts to increase, even before they become end-stage renal disease, they have relative vitamin D deficiency. So clinically, in terms of hydroxylation, the renal causes are much more important than the liver causes. The liver causes, you only get vitamin D deficiency only when you have end-stage liver disease, end-stage cirrhosis, and at that stage, vitamin D deficiency will probably be one of the least problems that this patient has with cirrhosis because they have a ton of other problems. So clinically, what's most important that we see in clinical practice is the renal causes in terms of hydroxylation of vitamin D. So once you absorb it, then you hydroxylate it, now you activate it, now you have active vitamin D. And what does your vitamin D do? Well, your vitamin D increases calcium reabsorption from the intestine. So the food that you get, the vitamin D that you get from your food, it increases reabsorption from the GI tract. It also probably increases reabsorption from the kidneys, from the tubules. So kind of an effect like parathyroid hormone. The only interesting thing that it does that's different from parathyroid hormone, and this is very important clinically because we're going to touch on this a little bit later, if you look right here, the effects of vitamin D, right at this spot right here, what it does is it increases proximal tubular reabsorption of phosphate. So vitamin D not only increases calcium in the serum, but it increases phosphate in the serum through reabsorption in the kidney. Remember, parathyroid hormone does the opposite. It increases calcium in the serum, but it decreases phosphate in the serum. This is very, very important in terms of assessing causes of hypocalcemia. Very important point. The third player here is calcitonin. Now, calcitonin is secreted through the calcitonin cell, the parafollicular cells in the thyroid, and it seems to be the hormone that really what it does is it puts calcium onto the bone. It puts calcium onto the bone, so basically if your calcium serum decreases because calcium deposits onto the bone with calcitonin. So it does the exact opposite of what really parathyroid hormone does to calcium in the serum. It puts calcium onto the bone and basically decreases calcium in the serum. Now that's why we like to use calcitonin in certain other diseases where calcium deposition onto the bone really matters. For example, we treat hypercalcemia with calcitonin because it puts calcium to the bone. We also treat osteoporosis with calcitonin for the same reason. It enhances, right, calcium onto the bone. So those are your three main players. And then I want to talk about just a couple of things more before we talk about hypercalcemia. I want to talk about this calcium that we measure in the serum right here. The calcium that we measure in the serum is bound to albumin. About 40% of the calcium that we measure in the serum is bound to albumin. This is very important because usually when you get a calcium from your comprehensive chemistry panel or from your Chem 7, your chemistry panel and all that, your basic metabolic panel, that calcium is not ionized calcium. It's ionized calcium, that's about 60%, and then the 40% is bound to albumin. Now you can ask for a specific study that only measures ionized calcium. It's usually done only specific labs, and it's difficult to do and it's expensive. So when we get calcium back routinely, unless you ask for the specific ionized calcium, it's bound to albumin. So any effects in albumin in the serum, any effects, anything that would decrease albumin in the serum, decreases total calcium, the stuff that we get, that we measure. So for example, a patient with nephrotic syndrome develops hypoalbuminemia. This patient will have a total calcium that's decreased. The ionized calcium, though, will probably be normal, can be normal. So you could adjust and really figure that out. So for example, we know that for any drop in albumin, for every drop in albumin of one single point, 1 milligram per dl, below normal, the amount of calcium is decreased by 0.8. So that's, we have to remember that number. So let me say it again. A decrease in albumin of a single unit, a single point, decreases your calcium by 0.8. I'm talking about albumin below normal. A normal albumin level is 4 milligrams per dl. So for every single drop of a unit below 4, the total calcium drops by 0.8. So every time we see hypocalcemia, and we're going to talk about this a little bit later, we have to adjust. If there's any hypoalbuminemia, we have to adjust for this, because sometimes the patient doesn't really have a low calcium, it's because the albumin. The second thing is that I want to point out to you is that basically calcium and phosphate are under constant ratios. So a big increase in phosphate decreases your calcium and vice versa. And we're going to see this is very important in end-stage renal disease, where phosphate levels, patients with end-stage renal disease can't get rid of phosphate, and your phosphate increases in the body. And what this does is, because these two are under a constant ratio, this decreases the calcium in the serum. That's very important. So another factor that plays in what your calcium, what your serum calcium does, is the amount of phosphate. When it's normal, it doesn't affect it that much, but when the phosphate is really high, what that does is it decreases the amount of calcium. So I want you to remember that. So that's what we need to know about calcium metabolism and the parathyroid hormone levels. And now we want to talk a little bit about hypercalcemia. Now, hypercalcemia is a common clinical scenario, and we see it commonly, and it's a big, differential diagnosis in making the diagnosis, because it's a bunch of very different diseases that cause hypercalcemia. Now, the most common one is hyperparathyroidism. That's why we have it number 1 on this list here. The most common cause of hypercalcemia all around, if you go across the board, with all causes of hypercalcemia, hyperparathyroidism is by far the most common one. And hyperparathyroidism, most of the time, is pretty benign. What I mean by that is the hypercalcemia is mild, maybe moderate, so you have minimal symptoms. In fact, when we talk about hyperparathyroidism later, you're going to see that maybe about half of these patients have really no symptomatology at all. They're asymptomatic, so this is picked up usually by chance just by doing a lab test and finding hypercalcemia. So the number one cause of hypercalcemia across the board in all cases of hypercalcemia is hyperparathyroidism, primary hyperparathyroidism. The second most common one is malignancy, and that's the big differential when we see people with hypercalcemia, where we say we have to exclude malignancy because that's also a pretty common cause. Now, malignancy causes severe hypercalcemia. If it's usually metastatic disease or aggressive disease that has caused the hypercalcemia. So the hypercalcemia of malignancy is usually severe. These patients usually have a lot of symptoms, and if they don't have symptoms initially, they will develop symptoms later unless you could treat the cancer, which is sometimes not treatable in this case because it's already metastasized. If you take cases of patients admitted to the hospital with severe hypercalcemia, so you take just that specific population, patients admitted to the hospital with severe hypercalcemia, the number one cause of those cases is malignancy, hypercalcemia of malignancy. So malignancy causes malignant hypercalcemia, a lot of symptoms, moderate to severe disease, not like hyperparathyroidism. There are two ways that malignancy could cause hypercalcemia. The number one cause in terms of frequency is the second one right here, is bone metastases. So for example, you have multiple myeloma, or you have metastatic breast cancer, and because of the METs, the metastatic disease to the bone, they activate locally tumor necrosis factor, interleukins, leukotrienes. They activate the osteoclasts locally, the metastatic sites, and basically what you do is you have release of calcium from the bone due to the metastatic sites. So this is, in terms of frequency, this is the most common form of hypercalcemia that we see with malignancy. But the other one that we also see, which is very interesting, and they ask us a lot on the boards for, is this thing called parathyroid hormone-like peptide that is secreted commonly from squamous cell cancer. Squamous cell cancer usually of the lung, but you could also have squamous cell cancer of the esophagus and head and neck area. So these squamous cell cancers secrete this parathyroid hormone-like peptide that works just like parathyroid hormone. What does parathyroid hormone do? It activates the osteoclasts to break down bone and release calcium into the serum. So it works exactly like parathyroid hormone to basically increase calcium in the serum, and that's how we get the hypercalcemia. The other interesting thing about squamous cell cancer is that it doesn't metastasize. It doesn't metastasize, it grows locally. It invades local structures, even when it's in the lung. And so you know that basically when it causes hypercalcemia, it's hardly ever through metastatic disease. It's usually through this thing called parathyroid hormone-like peptide. Now, one important other thing about this peptide, when we measure parathyroid hormone in the serum, the one that we're really measuring is the endogenous one that we get secreted from the parathyroid glands. We're not really measuring parathyroid hormone-like peptide. So the assay that you measure in the blood could tell the difference between a like peptide and the one that you secrete from the parathyroid glands. So basically, if I check hypercalcemia, a patient with hypercalcemia, and his or her parathyroid hormone levels are elevated, I know This parathyroid hormone only comes from the parathyroid glands, and this patient has primary hyperparathyroidism. Only patients, the patients that have the parathyroid hormone like peptide, their parathyroid hormone levels in the body will be decreased because this assay doesn't pick up this parathyroid hormone like peptide. So please remember that. So those are the two most important causes of hypercalcemia, but for the boards and clinically, we have to remember a couple of other causes that sometimes they ask us about. So the other one is sarcoidosis. Now sarcoidosis is very common, and patients with sarcoidosis, they develop a hypercalcemia basically by activating vitamin D through the macrophages, through the macrophages, through the granulomas. Now it's interesting, patients with sarcoidosis develop this kind of hypercalcemia usually in the summer months, or usually when they're exposed to sun, because now they absorb more vitamin D, and now they activate this vitamin D more through the macrophages, and that's how they develop the hypercalcemia. This type of hypercalcemia is unique, because if we're going to talk about the treatment of hypercalcemia a little bit later, but this type of hypercalcemia is basically treated with prednisone, just like the other cases of sarcoidosis are treated with prednisone. So it's very important that this is a little bit different than the other cases, because when you want to treat the hypercalcemia of sarcoidosis, you treat the symptoms and then you give them prednisone basically to suppress the sarcoidosis and eventually suppress the hypercalcemia. Another form of hypercalcemia that is very interesting is this right here, prolonged immobilization. Now you're going to see this if you're taking care of people in nursing home facilities or the geriatric population. People that are immobilized for a long time developed a mild hypercalcemia. So if they tell you about a case of a patient in a nursing home that's had a stroke and has been bedbound for a couple of years or so, and you find a hypercalcemia, and they ask you, what is this likely to be? Tell them it's likely to be from hypercalcemia from immobilization. Is pretty common, and what you do is you just watch it. As long as it doesn't increase, you basically just watch it. You don't do anything about it. Now let me tell you, think about the population you're also talking about, right? You're not going to be aggressive in this patient. This patient has been immobilized for probably some time, probably from a stroke, something else, some chronic disease. So you're not going to go and be aggressive about working up this patient and looking for cancers and stuff like that, because it's likely not going to make a big difference. But they may ask you on the boards, what type of hypercalcemia do you see in the geriatric population, people that live in long-term facilities, people that are immobilized? The answer is the hypercalcemia of immobilization, and it's pretty benign and we don't do much about it. The other type of hypercalcemia that we see is one related to hyperthyroidism, especially Graves' disease. So it seems that the hyperthyroidism activates the osteoclast, probably indirectly in some way, form, or another, and you develop hypercalcemia. So think about hyperthyroidism also when you see patients with hypercalcemia. And then this very interesting disease called familial hypocalciuric hypercalcemia also causes a form of benign hypercalcemia that we don't do much about. We really watch it because it's asymptomatic. Now, if you remember the name familial hypocalciuric hypercalcemia, you know everything you need to know about the syndrome. So the first thing is it's familial, so it runs in families, so people in the same family have this disease. They have hypercalcemia. Hypocalciuric, this tells you the essence of the cause of the hypercalcemia. Hypocalciuric, it basically, these patients have something wrong with their tubules and they don't get rid of enough calcium and they develop hypercalcemia. More so, it is the only cause of hypercalcemia where you have low calcium in the urine, hypocalciuric. It is the only cause. All the other causes, if you have a high calcium in the serum, your urine will get rid of more calcium, so you have a lot of calcium in the urine. The only one that you don't have it in, that you have hypocalciuric, low calcium in the urine, is this thing called familial hypocalciuric hypercalcemia. So in a nutshell, these patients, it's a genetic disease, it's familial, and what they have is they don't get rid of enough calcium and they develop hypercalcemia. It is asymptomatic and you don't have to do anything about it. You watch the patient, you don't have to do anything more about it. Just tell them that it's benign and you just watch it. The way to diagnose it is look for the calcium in the urine. If it's low, less than 20 milliequivalents, less than 40 milliequivalents, right, this patient will have only familial hypocalciuric hypercalcemia. Don't do anything about it. And then the last cause is some drugs. It's rare that some drugs do it, but the one that you need to remember for the boards is the diuretic hydrochlorothiazide. Now remember, if you compare hydrochlorothiazide to things like furosemide, furosemide has a calciuritic effect. It lowers the calcium in the serum by getting rid of calcium in the urine. Hydrochlorothiazide holds on to calcium. That's really the only difference that these two diuretics have. All the other side effects, the hypokalemia, the glucose, the lipid changes, they're all the same between hydrochlorothiazide and furosemide. The only difference is the calcium levels. Hydrochlorothiazide increases your calcium levels, furosemide decreases your calcium levels. So somebody on hydrochlorothiazide, if we develop hypercalcemia, maybe what we'll do in this patient is change this patient over to some type of other antihypertensive medication or another diuretic. That's the etiology, but what's the clinical scenarios that patients with hypercalcemia present with? So it's a combination of different things. The first thing, if it's severe, patients with hypercalcemia can present with CNS manifestations, lethargy, confusion, altered mental status, right? Like things like, they're not thinking well, they don't know where they're at, and so forth. And then the typical GI manifestations, right? Abdominal pain, constipation are typical, and then the renal, polyuria polydipsia, and polyuria polydipsia occur because patients with hypercalcemia develop a form of nephrogenic diabetes insipidus. We talked about this when we talked about diabetes insipidus. So they develop a nephrogenic diabetes insipidus and they develop polyuria polydipsia and they really develop severe dehydration. That's why when we treat these patients with severe hypercalcemia, the number one thing to do is we give them back a lot of fluids. They also develop, as a renal manifestation, kidney stones. So nephrolithiasis is a possibility that these patients develop, and that's why patients with nephrolithiasis, one of the first things we work them up for is hyperparathyroidism and hypercalcemia. And then cardiovascular manifestations, on the electrocardiogram, we usually find a short QT interval. That's the typical scenario with hypercalcemia, that the QT interval is shortened. So what do we do? How do we manage patients with severe hypercalcemia? This is not just mild hypercalcemia. These are patients that usually get admitted to the hospital with hypercalcemia, severe, significant hypercalcemia. That's what they're really asking you. How do you manage patients with significant hypercalcemia, usually admitted to the hospital? So the number one thing, and the number two things, and the number three things is to give them a lot of fluids. IV fluids is the number one, is the cornerstone of treatment of hypercalcemia. So we give them normal saline, we give them fluids, and we give them fluids again and fluids again. That's the treatment of hypercalcemia. Remember, these patients are at least 3 to 4 to 5 liters down because they have nephrogenic diabetes insipidus. Because the mainstay, the cornerstone treatment of hypercalcemia is IV fluids, once you start to give this patient a lot of fluids, especially in patients that are older with comorbid conditions, they may develop fluid overload. This is why if this happens after you give them a couple of liters, and especially if they develop edema and fluid overload, you have to add to the regimen furosemide. Furosemide, remember, is calciuritic. So you're going to not only get rid of the fluids, you're going to get rid of a little bit of calcium. Now, it's very important, though, that you understand that furosemide is in this regimen only because we give a patient a lot of fluids. That's the mainstay treatment. If you write an order on a patient for them to get IV fluids for hypercalcemia, and you write for them to get furosemide at the same time, say you're going to write furosemide IV push 60 milligrams of furosemide, you know, the nurse is going to hang the IV fluids and keep it wide open because you got to give the patient a lot of fluids, and then at the same time is going to go and give the furosemide. And then what you really do at that time, you dehydrate the patient even more. The patient gets even more dehydrated. Their hypercalcemia worsens. So be careful, furosemide is only given after we've hydrated the patient, and especially if the patient develops fluid overload, a little bit of crackles in the lungs, a little bit of edema in the legs and stuff like that, then you say, okay, now I got to give the furosemide. Or you could give it after you give a couple of liters. That's okay to do, but after you've hydrated the patient, please be careful of that clinical scenario. Because patients with severe hypercalcemia coming into the hospitals, I told you, most of the time have hypercalcemia related to malignancy. Despite the fluids, once you stop the fluids, once you send the patient home, once you minimize these fluids, the hypercalcemia will bump up again. Because remember, the disease doesn't go away. Metastatic cancer to the bones, or metastatic lung cancer, squamous cell cancer, and stuff like that doesn't go away unless you treat the cancer. In most of these cases, they're untreatable. So what do we do to basically keep the calcium down? For weeks, we give them fluids, we tell them to drink a lot of fluids, but we give them things that could put calcium onto the bone and remove it from the serum, things like biphosphonates. So if they ask you, okay, after you treated the patient with a lot of fluids, what's the next step to keep the patient's calcium down? The answer is give them biphosphonates, like pamidronate. Remember, pamidronate is long-acting. It's a long-acting biphosphonate. Alendronate. Alendronate is Fosamax, what we use for osteoporosis, especially in women with osteoporosis. We don't like to use too much with hypercalcemia because it's short-acting. Pamidronate is more long-acting, and it works over weeks. So if they ask me, how do I manage a patient with multiple myeloma and hypercalcemia, my answer is, after I give them a lot of fluids, I'll give them a touch of furosemide, and then I'll give them biphosphonates, like pamidronate, to keep his or her calcium low so they don't have to come into the hospital all the time. And I'll repeat a treatment with biphosphonates, so I keep that calcium within normal limits. The only problem with biphosphonates is that it takes about 24 to 48 hours for it to start working. So it takes 2 days for it to start working. So they may ask us, well, wait a second, what are you going to do in those 2 days if you have severe hypercalcemia? And maybe you can't even control the severe hypercalcemia with IV fluids. Do you have any other drug that you could use? And the answer is yes. I could use calcitonin. Here it is. Calcitonin, you could use calcitonin right away, and it will affect the calcium within a couple of hours. So depending on when they want you to lower the calcium and how, if it's severe hypercalcemia and you can't control it with normal saline because this patient has, metastatic disease, and you can't control it with normal saline, you can't wait for the biphosphonates. You'll give them biphosphonates, but you can't wait for the biphosphonates 2 days later. You may give them a touch of calcitonin to lower their calcium for the first couple of days, and then allow the biphosphonate to kick in 24 to 48 hours later. Now here's the interesting thing. If you give calcitonin, after 2 days, the effect of calcitonin on calcium wears off. It wears off. So if you only give patient calcitonin, then the calcium rebounds after 2 days. So if you want to keep that calcium low, you're going to give them calcitonin, and then at the same time, give them biphosphonates. So 2 days later, when the calcitonin effect is wearing off, the biphosphonate effect is kicking in, and it keeps the calcium down to normal levels. So that's the way you manage hypercalcemia. Please know how these drugs work, because they'll change the scenario around, and then you'll have to use these drugs accordingly. So let me give you an example. A patient comes in with severe hypercalcemia into the hospital. What do we do first? We give them IV fluids. Yes, we'll give them a little bit of furosemide along with that. And then they tell us, you can't keep that calcium normal, right? This patient has multiple myeloma. You can't keep it goes back to normal, and then it bounces up to high levels. What do you do next? How do you get it down really quick? The answer is you give them calcitonin. And then they ask us a third question. How do you keep that level of calcium low for weeks later so the patient could go home? The answer is we give them biphosphonates, pamidronate. That's going to act 2 days later, and it's going to have an effect for at least a couple of weeks. So depending on what type of question they're asking you, where do you want the effect to take, right? That's how you use these medications. People that have mild hypercalcemia, you don't have to give them calcitonin. All you have to do is give them biphosphonates, because you have a couple of days to wait until the biphosphonate kicks in. Mild, maybe moderate. So that's not bad. You have a couple of days until the biphosphonate kick in. If it's severe, though, and you can't get it down with just fluids, or it comes up again despite the fluids, well, then calcitonin is the drug of choice. But remember, it's going to wear off after 2 days, so you have to have biphosphonates on board. So that's the management of severe hypercalcemia. Remember how we manage these patients. They're very, very important. Now, I want to talk a little bit about primary hyperparathyroidism. We talked and we said before that this is the most common cause of hypercalcemia. It is the most common form of hypercalcemia across the board. It's usually caused by a single adenoma causing a secretion, autonomous secretion of parathyroid hormone. That's the case in about 3/4 of the cases, and about 25% of the cases, we may have 4-gland hyperplasia. So it's important, because you have to know that. The surgeon, when you go in and you take it out, has to know, is it a single gland or 4-gland hyperplasia? So before these patients are taken to surgery, you have to do some kind of imaging study to find out which one of these two you got. Is it a single gland, so they go in and take out the single gland, or 4-gland hyperplasia, where they have to take the 4 glands out, and sometimes what they do is they put a piece of the parathyroid gland in the forearm here just to assess the calcium levels, and then basically, take more of the parathyroid gland off, but now they have it close proximity, it's in the forearm, because the vascularization there is good, so you could have it there and it works very well. And then about 1% of the cases of hyperparathyroidism, primary hyperparathyroidism, are due to cancers of the parathyroid glands. These are very, very rare. So most of the cases are benign. A single adenoma accounts for 3/4 of the cases, and then 4-gland hyperplasia occurs about 25% of the time. We talked about before about these diseases called multiple endocrine neoplasias, and hyperparathyroidism is also another disease, just like medullary cancer of the thyroid, that is involved in multiple endocrine neoplasias. Now, multiple endocrine neoplasia 1 has hyperparathyroidism, and these patients also have pituitary tumors and pancreatic tumors. And then multiple endocrine neoplasia 2 also has hyperparathyroidism, and then these patients have pheochromocytoma and medullary cancer of the thyroid. So men 1 and 2 both have hyperparathyroidism, and then something else. Men 1 has pituitary tumors and pancreatic tumors, and then men 2 has the pheochromocytoma and the medullary thyroid cancer. So they sometimes ask us, well, what do we do next after we discover hyperparathyroidism? And the answer is, you look for these multiple endocrine neoplasia syndromes, because they could be subtle. So you investigate this patient for medullary cancer. You make sure they don't have anything that looks like pheochromocytoma. You look for pituitary tumors and stuff like that. It's not very common that you find these multiple endocrine neoplasias, but a lot of the hyperparathyroidism are associated with them, so you have to look for them, you have to exclude them. Primary hyperparathyroidism, I told you, in about 50% of the cases, these patients have no symptoms at all. They're totally asymptomatic, so these patients are discovered incidentally. Somebody gets a comprehensive panel or a metabolic panel and notes that this patient has hypercalcemia and then investigates it and finds that the patient has primary hyperparathyroidism. So it really tells you the essence of the disease, that 1 out of every 2 cases are so mild that they're totally asymptomatic. So that generally this disease is mild, generally mild, much more benign than the one related with malignancy, of course. In some cases, in about 50% of the cases, these patients have symptoms. And a couple of the symptoms that we have to talk about is these bone effects. So if your parathyroid hormone is secreted continuously, autonomously, what it does is it affects the osteoclast continuously, and what this does is it breaks down bone and forms these cystic spaces in the bone, and this is called osteitis fibrosa cystica, or brown tumors. What these are right here is effects of parathyroid hormone on the osteoclast, and the osteoclast effect on the bone to break down bone and cause these cystic spaces. So what these really are is the effect of chronic activation of osteoclast on the bone. So you may hear the term brown tumors because they look on the x-ray like these brown tumors, but they're really cystic spaces. That's all they are, and it's from chronic activation of the osteoclast. Of course, if you activate your osteoclast and you break down bone, you develop hypercalcemia. And we said once you develop hypercalcemia, this also may cause nephrocalcinosis. It may cause kidney stones. It causes a type of nephrogenic diabetes insipidus. So these patients commonly present with polyuria, polydipsia. And then if the hypercalcemia is severe, I said these patients sometimes present with central nervous system effects. Central nervous system effects, confusion, right, altered mental status, and so forth. Fortunately, the neuro effects are much more profound in cancer. They're not usually seen in primary hyperparathyroidism, but can be seen sometimes. And then we may have GI manifestations like constipation, nausea, vomiting, and abdominal pain, chronic abdominal pain, right? The mnemonic of moans and groans and stuff like that pertains to, it's relative to primary hyperparathyroidism and the hypercalcemia of hyperparathyroidism. Now, how do we diagnose this disease? This is the only disease that causes hypercalcemia and an elevated parathyroid hormone. It's the only disease. All the other ones, the parathyroid hormone is decreased because the hypercalcemia suppresses the parathyroid hormone. So the first test we do in hypercalcemia to work up hypercalcemia is we check a parathyroid hormone level. If it's elevated, it's only one cause. It's primary hyperparathyroidism. And that's the end of story. How do we manage these patients? Well, this is really a surgical disease. Do we have to do surgery in everybody? The answer is no. We don't have to do surgery in everybody, but it is a surgical disease because that's the definitive treatment, and we treat everybody with surgery that has symptoms. Any symptomatic patient we have to treat with surgery. Young patients also have to be treated because they will eventually develop bone disease. And then after the surgery, sometimes we see this hypocalcemia after the surgery. It's called hungry bone syndrome because once you take away all the parathyroid glands, the other ones are they're not working well. So what happens is all the calcium goes and deposits onto the bone, and this is called hungry bone syndrome. And what they're telling you on the boards is once you do surgery for primary hyperparathyroidism, you have to watch this patient at least for a couple of days so as to not have this happen. If this happens, you have to give the patient calcium in the hospital and watch them. So the medical management for hypercalcemia we talked about already. Let's say this patient is old and you don't want to do surgery in them. You have to do fluids and you have to do biphosphonates long term. But generally, we reserve only people, this kind of treatment for people that are older and have comorbid conditions, because the younger people we want to do surgery, the symptomatic people we want to do surgery in. Before you do the surgery, you have to get some imaging study, either an MRI of the neck or an ultrasound of the neck, to diagnose if you got four-gland hyperplasia or single adenoma. And after that, you proceed to surgery. And that's our case for primary hyperparathyroidism. From hypercalcemia, we want to go and talk about hypocalcemia now. And we want to talk a little bit about the etiology first. And there's basically three groups of diseases that could cause hypocalcemia. And the first one is hypoparathyroidism. And this is usually in the adult patient. It's usually acquired. And it's usually related to some kind of surgery around the parathyroid glands, usually either thyroid surgery or some kind of cancer surgery in the head and neck area and so forth. So usually the history is there. When the patient develops hypocalcemia, that this patient before had some type of surgery recently close to the parathyroid glands, to the neck area and so forth. So this is usually not a conundrum, a difficult case, because we have the history of surgery. The second scenario is, the second big group of diseases is vitamin D deficiency. And vitamin D deficiency, if you remember, all the causes of vitamin D deficiency could be any one of those. We talked about renal causes, because you don't hydroxylate with renal disease, you don't hydroxylate your vitamin D at the one site. We talked about cirrhosis, when you don't hydroxylate at the 25th site, and this, I said, is usually rare because it usually occurs only with severe liver disease. And then we talked about intestinal malabsorption with things like celiac sprue, Crohn's disease, or things like chronic pancreatitis, where you don't have pancreatic enzymes. And then we talked about some other more rarer causes that we could see in older patients, because they don't get enough sunlight, because they stay in the bed all the time and they don't get access to sunlight, and you don't absorb vitamin D through the sunlight and so forth. So vitamin D deficiency is the second big category that we have to consider in hypocalcemia. And then the third one that we tend to forget, and I wanna make sure that you remember this for the boards, is hypomagnesemia. Hypomagnesemia, in all cases of hypocalcemia, we have to check a magnesium level, because you need adequate amounts of magnesium, one, to secrete parathyroid hormone normally. So you need the magnesium in order to have normal parathyroid hormone secretion. And you need magnesium for parathyroid hormone to work on the osteoclast receptors, to basically activate the osteoclast and release calcium from the bone. So magnesium plays in two areas where you could have problems with your calcium metabolism, directly because it affects the parathyroid hormone release, and number two, it affects the effects of parathyroid hormone on the osteoclast receptors. So please always, with hypocalcemia, check a magnesium level to make sure it's normal. Otherwise, you have to replace it. And if you replace it, you sort out the hypocalcemia right away. Well, what are the clinical findings of hypocalcemia? Well, a couple of things that most of us know about. The neuromuscular irritability. Remember, you have to have normal calcium to have normal neuromuscular function. So when you don't have calcium, you develop neuromuscular irritability and tetany, laryngospasm, cramping, seizures. So it's very common for these patients to come and they say, I have a lot of cramps in my muscles and stuff like that. And more severe forms present with tetany and laryngospasm. There's two signs that we have to remember for the boards that cause, these point to latent tetany, right here. Cross-deck sign and Trousseau sign. Both of these point to latent tetany. Cross-deck sign is basically if you tap over the facial nerve, the patient develops twitching because of the latent tetany. And Trousseau sign is you basically put the patient, you put the cuff, a blood pressure cuff on the patient, you inflate it, keep it there for about a minute or two, and because you cut off the circulation, the patient develops tetany in the hand, and you see it develop right in front of your eyes. So Kostek sign and Trousseau sign both are evidence of latent tetany. And then the cardiovascular manifestations beyond the arrhythmias that hypocalcemia could cause, on the electrocardiogram, it causes a QT prolongation. That is the typical finding of hypocalcemia on the electrocardiogram. How do we make the diagnosis of hypocalcemia, and how do we manage and work up patients with hypocalcemia? So this is a very, very important slide. If you could take one slide from the hypocalcemia away, this is the most important one. So a patient presents to us with hypocalcemia. What is the first thing we do? The first thing we do is we don't check parathyroid hormone levels, we don't check any vitamin D levels. The first thing we do is we make the correction for albumin. We check the albumin and make the correction, because remember, at the start of this talk, I started off by telling you that when we measure calcium, we measure total calcium, and that about 40% is bound to albumin. So the first thing you want to look at is this true hypocalcemia, or is it an effect from the low albumin? Maybe this patient has some kind of reason to have low albumin, and this is why the patient developed hypocalcemia, and it's not really true hypocalcemia, it's because of the low albumin. So the first thing we do is we check the albumin, make the correction. If the correction makes the calcium normal, then we don't have to worry about the hypocalcemia. We have to see why the patient has a low albumin and find the cause of the low albumin and treat that. The correction is, for every decrease in albumin by 1 point, there's a decrease in calcium by 0.8. Right? So, for example, if the patient's calcium is 6, and this patient's albumin has decreased by 1, you'll add 0.8 to that 6. So his real calcium is now 6.8, right? Because of the albumin, it dropped the albumin dropped by 1 point, the calcium dropped by 0.8 at the same time. So you add a 0.8, right, to correct for the calcium and see if this is true hypocalcemia. That's the way we go about that. So if the patient has true hypocalcemia, then the next step is to check a parathyroid hormone. If the parathyroid hormone is low, then it could only be one thing, hypoparathyroidism. If it's high, then it's vitamin D deficiency, and this patient is high because they have what is called secondary hyperparathyroidism. Right? It's high because the calcium is low because there's no vitamin D. So the vitamin D decreases your calcium level, and what this does is it increases the parathyroid hormone, because the parathyroid hormone tries to adjust for the drop in calcium. So that's called secondary hyperparathyroidism. On the boards, they sometimes don't give us the parathyroid hormone level. What they do is they give us a combination of calcium and phosphate. So if you remember what we said, how the parathyroid hormone works, you could figure this out. So in patients with hypoparathyroidism, they have a low parathyroid hormone level, but they may not give that to us on the boards. What they'll give us is that they have a low calcium, and then they'll give us a high phosphate. Remember, your parathyroid hormone increases your calcium and gets rid of phosphate. So when you have low parathyroid hormone levels, your calcium goes low and your phosphate now is reabsorbed, because you have no parathyroid hormone to secrete phosphate in the urine. With vitamin D deficiency, it's very interesting, because now we have a high PTH, secondary hyperparathyroidism. The low calcium is what causes the high PTH, But now, because the PTH is high, the parathyroid hormone is high, your phosphate is low. Why is it low? Because your parathyroid hormone acts on the kidney, and what it does is it blocks the reabsorption of phosphate. So please, when you look at patients with hypocalcemia on the boards, the first thing you look at is look at the phosphate level. If the phosphate is high or normal, we're talking about hypoparathyroidism. If the phosphate is low, like here, we're talking about vitamin D deficiency. Please, that's the #1 thing to look for to figure out what is going on with the patient. That's the most important thing that you look at in hypocalcemia when they don't give you the parathyroid hormone level. And then the third thing that we should have said here is what you check is the magnesium levels. Remember, we want to rule out hypomagnesemia here as a cause of hypocalcemia, so we check the magnesium level to make sure that that's not the cause of what's going on with this patient. How do we treat this patient? How do we manage further? The answer is, if the patient has any evidence of tetany, any symptoms, any evidence of either latent tetany or laryngospasm or muscle cramps, then we have to give the patient IV calcium gluconate, right? We have to reverse the hypocalcemia acutely. We have to give the patient IV calcium gluconate. That's the best form of calcium to give. That will readjust the calcium in the serum the quickest possible way. So any type of symptoms, especially laryngospasm, latent tetany, IV calcium is the drug of choice. If the patient has very mild symptoms, and then you need only maintenance therapy, and then those patients only get oral calcium, they get about 2 to 4 grams per day, and then we give them vitamin D if they're missing vitamin D, right? These patients should get vitamin D because a lot of these patients usually have vitamin D deficiency. I don't mean that everybody gets vitamin D. Everybody gets vitamin D. It's only the patients that have vitamin D deficiency. They get oral calcium. They get plus vitamin D in the case of vitamin D deficiency. Now, the way we give vitamin D is we have to give the activated form. That's the best way to give vitamin D because now the patient doesn't have to hydroxylate it. So you give the 125 form of hydroxy vitamin D, activated form. And the patient that's the easiest form to give a vitamin D, and it has the quickest action on the absorption of calcium. In patients, especially with end-stage kidney disease, who develop hyperphosphatemia, these patients right here, these are patients with end-stage renal disease. So a patient starts off with vitamin D deficiency because they have mild kidney disease, and then years later they go into end-stage renal disease, and now they have not only vitamin D deficiency, but they develop hyperphosphatemia because they have no urine output. Remember, the end-stage renal disease patients, these are dialysis patients. You can't get rid of phosphate through your urine when you develop end-stage renal disease, and you can't dialyze phosphate easily. You can't dialyze it. It's very difficult. So these patients develop hyperphosphatemia. And what that does is, once your phosphate increases, remember I said phosphate and calcium is under a constant ratio, so when your phosphate increases to high levels, your calcium goes down even further. So patients with end-stage renal disease not only have vitamin D deficiency, but they have, not only do they have vitamin D deficiency causing hypocalcemia, but they have hypocalcemia further worsened by hyperphosphatemia. So in these patients with end-stage renal disease, do diet restriction, give them phosphate binders, right, aluminum hydroxide, and so forth. And you'll see, if you look at your patients with end-stage renal disease, they get dialyzed, they're always on phosphate binders. The reason they're always on phosphate binders is this, to suppress the hyperphosphatemia and basically to minimize the hypocalcemia because of the hyperphosphatemia. And this concludes the chapter for the parathyroid glands.